So I'm primarily a psychiatrist working at the University Psychiatric Clinic in Ljubljana, and I'm involved in a unit which is treating treatment-resistant patients with treatment-resistant depression. This means patients who are not responding well to either to drug therapy or to other classic like psychotherapeutic approaches. So what we do, we try to use so the methods that are now available, this developments in the field of non-invasive brain stimulation on one hand to treat patients, and also will be in charge with implementing other new treatments that are now being in development around the world, like fast-acting antidepressants. We'll be implementing them and using them in Slovenia in future. So today I would like to give you an overview of how this field of TMS, treatment of depression, has changed in, let's say, last 5 years. There were some very important and big developments. And if we start from the beginning, for those of you who don't know how TMS works, or especially for therapy, it's what you can see here. We have a machine which is able to produce fast discharging of a lot of energy, and this the flow of this electrical current then produces very short electromagnetic pulses, which induce, if the coil with this, where the electric current flows, is put close to the scalp, these electromagnetic pulses can reach the brain, go through the bone, and induce electrical activity in small area underneath this so-called TMS coil. So the point of this treatment versus other possible non-invasive treatments is that it's very focused. We can stimulate an area which around 2 to 3 square centimeters, for example, and therefore it's ideal to try to change the activity of separate or individual brain networks compared to other possible stimulations, non-invasive, like transcranial direct current stimulation, which is much more diffuse. In that case, we are stimulating or changing the activity of the whole hemisphere or something like this. And so these protocols of how to use TMS were all developed on motor system, because in the motor system it was quite easily to measure the effects through the influence of pulses on so-called motor evoked potentials in hands or feet. And the principles of how they think that the TMS work is that it's possible to pattern it in different patterns, and some patterns actually increase the excitability of the area that we are stimulating, while the others can decrease it or inhibit it. And for depression, I mean, what they have found also, which was very important in studies in motor system with people who had cerebral infarctions, so the ischemia or cerebrovascular incidents, was that both hemispheres are usually in balance. So if there is a damage in one of the hemispheres, like for example in the left one, the right one would at the same time gain dominance across this less functioning left hemisphere and start to be to a certain extent hyperactive. So the principle of trying to influence this imbalance is either to stimulate the damaged part, the damaged hemisphere, or to inhibit the one that's healthy but overactive because of the imbalance. And the same is probably valid for depression, and this is how we came to first select to the selection of the first targets for depression treatment. Because in neuroimaging studies, it was shown quite early that in depression, what we can see is a hypoactivity of left dorsolateral prefrontal cortex, and at the same time, but not so robustly, the hyperactivity in the right prefrontal cortex. And the first protocols that were developed were so-called repetitive pulse protocols, simple ones which can either be low frequency, like 1 pulse per second, or 1 hertz treatment. This is inhibitory for the brain region. Or you can have so-called facilitatory or high-frequency protocols, and an example of them is a 10 hertz protocol, so 10 pulses per second. Everything that's above 5 hertz is considered high-frequency and usually facilitatory. So what you can do, or what they have done in early days of TMS treatment of depression, was to either use left-sided facilitatory 10 hertz protocol to try to stimulate the hypoactive part of the brain, the left DLPFC, or use inhibitory 1 hertz protocol to inhibit the right DLPFC. Or you could use both protocols. It was never shown that any of these protocols would be superior to another. So in clinical practice, what gained prominence was just this left-sided facilitatory 10 hertz protocol, which was then probably used in majority of treatment centers. But then later on, there was an important development that people came to the idea that maybe perhaps we could try to simulate what's actually going on in the brain. So to simulate the patterns of neuron activity that are actually happening in living brain. And they proposed to use so-called theta burst stimulation, because this pattern is closer to what we can observe in if we put intracranial electrodes either in animals or humans. And this means that we apply triplets of pulses in a very fast frequency, and therefore they are called bursts, because we cannot really separate them from each other by observing. And these bursts of 3 pulses in 50 hertz frequency are then repeated similarly to pulses in older protocols, for example, 5 times per second, and this is called theta burst protocol, because the frequency falls in the so-called theta range, which is from 4 to 8 hertz in EEG studies. And you can, they have also discovered that you can have facilitatory and inhibitory theta burst protocols, and you can then repeat the same logic to either stimulate the left hemisphere or inhibit the right, or do both. What was also discovered early on in this early phases of treatment was that the clinical effectiveness of TMS depends on the total number of pulses. So it's either the total number of pulses that are given during a daily session, because the treatment is given in daily sessions, which are then repeated each day up to up to, let's say, 20 to 30 sessions in the overall treatment course. And the number of pulses that you give in a daily session predicts the response rate. And also the remission rate, how successful we will be by treating the patients. And for older protocols, the effectiveness is about, you can count that perhaps 25 to 30% of people will have meaningful reduction of symptomatology. And these are people who were resistant to medication. So in clinical practice, that's important, because for 1/3 of people who you could not help with other more standard psychiatric treatments, this can be a solution. But we don't know yet which ones are responding and why. And so that's why all of this research, which comes from neuroscience and understanding the brain function, is important for development of better effectiveness of treatments. Then the centers which were treating came to the idea that perhaps we could use accelerated protocols, so-called accelerated protocols. In the beginning, they were considered a bit risky because nobody knew what would happen if you would give more than one session of treatment per day. But then people started trying, and they realized that it doesn't really matter. You can give up to 10 sessions per day and still not increase any kind of risk for any kind of known side effects. These side effects are not usually not serious. They are more or less unpleasant. The only serious side effect of TMS could be lowering of epileptic threshold, but this happens only if you use very high frequencies for stimulation, let's say around 20 hertz or something, which we are not using in clinical practice. So the standard protocol which I was describing, we measure the motor threshold, so the threshold where the motor system responds to the pulse. And then we use 120% of this intensity for stimulation, and we give up to 3,000 pulses in one daily session, which lasts quite long, for 40 minutes. And then we repeat these daily sessions for 20 or 30 times in a row, and this comes to 4 or 6 weeks of treatment. So treatment is delivered in weekdays from Monday to Friday, and the rest days over the weekend. And they can come up to 90,000 pulses in the overall course of treatment. While these changes in accelerated treatment protocols, what they did, they tried to do multiple sessions per day just to shorten the overall treatment duration. They saw that it's improving the clinical efficiency and possibly even bringing about a faster onset of antidepressant effect. But there was a lot of heterogeneity between all studies and study designs because nobody knew exactly in which way to go. So centers were trying just different things. They were trying different stimulation targets, different frequencies, different intensities, different number of pulses per daily session, and in overall treatment course. They were also experimenting with how much you need to leave time between two sessions in the daily treatment. And then later on, they also introduced the theta burst protocols in an accelerated fashion. And those proved as the most successful development, because we can now have a much shorter duration of daily sessions, which is only 3 to 10 minutes compared to up to 40 in the past. People can give up to 10 daily sessions without any increase in risk for side effects. And this shortens the total treatment duration to 5 to 10 days. This means 2 working weeks compared to 6 in the past, which is for psychiatric practice, especially in the hospital or hospitalized patients, it's extremely important to, if we want to enable, if we want to get to the point where we'll be able to give this treatment to anybody who needs it. Because right now, the main limiting factor is actually staff. So there is not, it's a lot of work burden to perform this type of treatment on a patient if you compare it with giving just a medicine and then having a checkup after a couple of weeks. So the next very important milestone was actually 3 years ago when there was a study at Stanford, which where they developed so-called Stanford neuromodulation therapy protocol. They tried to combine all the new advancements. So they used an accelerated treatment with theta burst stimulation. They They used a certain technique where they tried to measure how far the cortex is from the skull, and depending on this, they would adapt the intensity of the pulse itself. So the less, the closer the cortex was to the skull, the less intensity we would use to reach it. They used 1,800 pulses and repeated the whole 10 daily sessions. So they could finish the whole treatment in a week, and they still delivered the maximum amount of pulses which were so far used in studies and proven to be safe. They also included neuronavigation, and they used the last state-of-the-art resting state functional connectivity to try to locate the individual DLPFC target in the individual, and this target selection was based on the seat connectivity from the subgenual anterior cingulate, because this, like Grega was showing, this is a region which is part of the limbic cortex or the network that's involved in emotion processing, which is usually hyperactive during depression. And similarly as amygdala, the subgenual anterior cingulate shows a negative correlation with DLPFC, which we interpret that this control network is somehow in interaction with the limbic network and trying to regulate the expression of emotions. So what they saw during the first proof of principle study, and then later on in a confirmatory placebo-controlled trial, was that the effectiveness was much higher than in all previous TMS treatment studies. So based on these results, they could get an FDA approval the same year, and they're planning, at least in the United States, to offer psychiatric clinicians machines with the whole method incorporated to be available commercially. So what we can conclude from this study, that using this type of protocol and accelerated theta burst protocol, we can have potentially better efficacy and definitely very big improvement in ease of use, and therefore also availability for much more patients, especially if they are acutely ill with severe forms of depression and staying in hospitals. But the added value of neuronavigation was not clear, at least not based on results of this study, because they did not include a comparative arm which would compare the neuronavigation they used with an arm without a neuronavigation. So the FDA approval currently does not require any kind of specific neuronavigation method for the accelerated theta burst protocol. But, and this is, we could say that let's just skip the neuronavigation, because it's quite, it takes a lot of time, it demands a lot of specialized knowledge and so on. Also, you need to scan people, so it's not readily available for outpatient practice and physicians working alone. But it's possible that neuronavigation would bring much more advantages in the future. So a lot of centers are currently investigating its usability. What happened in the past was the first line of research was they just tried to see if we use a structural MRI image of a patient and locate his individual coordinates for the Brodmann area, border between Brodmann areas 46 and 9, which was an accepted standard group target for DLPFC. Would this provide better treatment results than if we use other more primitive or earlier methods of how to localize the DLPFC? And the oldest method was a very simple one. People just went 5 centimeters in anterior from motor cortex, which is easily to identify because we can see the motor evoked potentials. And then if you just go 5 centimeters in front, you should be somewhere around DLPFC. So the studies could prove, of course, that if you use a structural MRI coordinate, that this would be superior to this 5 centimeter motor hotspot method, but it's surprisingly not superior to another method which will be described by my colleagues later on in more detail, which is called a BEAM-F3 method. And this is a method where we use EEG cap coordinates, and the F3 coordinate for the F3 electrodes electrode corresponds approximately to the DLPFC location. So what they another group has shown in a landmark study was that the BEAM-F3 method is quite comparable to a structural MRI target location. So that in practice there is probably no use to use structural MRI imaging, because you would only gain around half of centimeter in 50% of subjects, or maybe up to 1 centimeter in 90% of subjects, which is in practice not really important, because in reality the coil can move around in this extent anyway during the stimulation. So the structural MRI was somehow ruled out. Nobody's really counting on it anymore for neuronavigation. But then the functional connectivity shows much more promise. And this is because of what Grega was describing. There were studies like 10 years ago, 2 important studies. One was from the group of Professor Bakken in Belgium. What they found is that this standard 10 Hz stimulation is much more efficient in patients who show a higher negative correlation between subgenual anterior cingulate and prefrontal cortex at the baseline before we start treating. So if there is a higher negative functional connectivity or correlation between activities of these 2 regions, the treatment will be more successful if we target the DLPFC. And also that this treatment brings about a change in the functional connectivity, because this negative correlation in people who responded to treatment is reduced after treatment, so that there is somehow a visible change in connectivity after successful treatment. And then there was also at the same time a study by a group of Professor Fox in the United States. He compared all of these different targeting methods, and what they saw that it's not really about the method. It's more about if the patients were again showing the greatest negative correlation between subgenual cingulum and DLPFC, then the therapy was most efficient. So they suggested that this is the way forward, that we should actually always try to compute the connectivity between these 2 parts of the brain, and then use the subgenual cingulum, which is easy to locate, and it's quite invariable in humans because it's a subcortical structure, to use the seat-based connectivity to see which areas in the DLPFC are most strongly correlated with subgenual cingulum, and then select target on the DLPFC based on the strength of this correlation. So this is what they use then in the Stanford Neuromodulation Therapy Protocol, exactly this approach. What they have in the proof of principle study, what they have shown, as I already described, they used the 10 daily sessions over 5 days of accelerated theta burst protocol. But what's interesting now for the neuronavigation is that what they found that the targets which were based on the functional connectivity with the subgenual cingulum, were on average 2.5 centimeters away from the standard target that we would determine with all other previous methods. And this is now clinically important because if you never accidentally move the coil for such an extent, and it's also therefore it's possible, at least based on results of this study, that we are not treating patients optimally, and that this could be the explanation why they had such a higher efficacy of treatment in their trial. And then there was a replication study, which was a placebo-controlled clinical trial to see if this is really clinically important or not. And the results were the same. Again, the targets were far away from, at least relatively far away from the standard location. And the efficacy was extremely better than in previous treatments. Surprisingly, the efficacy was actually the best after 1 week of treatment, because before we always thought that TMS works similarly to medications, that you need to wait for a couple of weeks before the whole effect will develop, perhaps related to neuroplasticity or not. But here it seems that the highest effect is in the first week, and then it slowly reduces, but it still remains much higher than with standard protocols. So this could be the end of the story. We could just use the DLPFC target and use the seed-based functional connectivity. But the point is depression really just one disorder with one pathophysiological mechanism? Probably not. We think that based on neuroimaging studies that there are at least 4 networks involved in depression. And these 4 networks are independent, like independent resting brain networks or task networks. One of them is a control network, a cognitive control network. The other one is the one I was talking about, the limbic network, where subgenual cingulum is the part of it. There is also a default mode network, the one that activates during rest, and which is related to this rumination symptoms in depression, so this brooding. But there is also a network which is related to anhedonia. Anhedonia is a part of the clinical picture of depression, the lack of positive effect, so lack of energy or motivation or ability to feel pleasure, which is quite different from the negative effect or the symptoms like anxiety or sadness and so on. In the clinical studies, we see that with usual antidepressants, we cannot really treat anhedonia properly. But based on the results from neuroscientific connectivity studies, it's possible that this is because there is a completely separate underlying network. So this means, if this is true, it means that we should try to personalize the TMS treatment, which is capable of stimulating any of these networks if we find the proper target with the functional connectivity. If we do it in this way, then we could perhaps also try to improve results in people who suffer because of anhedonia. And that's why, and this is another reason why it's so important to try to develop functional connectivity methods in resting state MRI. And there are now studies which are trying to do this at the forefront of developments so this is the one, for example, one example where they have tried to segregate symptoms and see which symptom clusters are represented in which parts of the brain. And they, for example, in this study, they came to the conclusion that you could get to 2 clusters of symptoms, and one would be a dysphoric cluster, probably related to this limbic network, and another one, a so-called anxiosomatic cluster. But what's important is that even if you look at the dorsolateral prefrontal cortex, these 2 symptom clusters have different targeting areas. So if you would want to approach just one cluster of symptoms in a specific patient, you could calculate this map and then select your target based on the symptoms you would like to improve. So it's a very interesting line of development. And there are methods now proposed for how to do the individual network targeting, where you could first identify the individual mapping of his individual functional networks. Then you could choose the network you want to stimulate. Then you would try to represent the target area for this network in a more robust way to take into account the gyral anatomy. So because with the coil you need to get to a horizontal surface because you cannot stimulate the vertical surfaces. And when you have this representation, which parts are the best to stimulate in an area to target, let's say, frontoparietal network, then you could also use modeling of the electrical field under the coil to see how to position the coil with neuronavigation software and hardware to have the best results. So in this way, we could come to the point where we could actually start stimulating like very small areas of cortex, less than ½ centimeter, depending on, which would be also dependent on knowing how to orient the coil in which direction. So here I will stop, and my colleagues will now talk more about the detailed, about how to develop these methods. Thank you.